deliberately build patient on priorities into the picture. So, but there is a hard practical Nigerian reason too, right? So not just the values reason. With our nurse to patient ratio, it's hard to have a nurse that will do nurse rehabilitation, right? Patient do enormous amount of actual care by themselves, feeding, positioning, mobilization. That's why we leave the responsibility sometimes with the patient relative, like repeating the exercise a certain amount of time during the day. This is something that actually the rehabilitation nurse would have handled, not the patient relative. So if you do not teach the family and bring them into the goals, the plan would simply not happen between the sessions, right? Once you do it and you leave, that's it until you return back. And if that's the case for our hypothetical patient, Mr. Konko, his wife, in effect, that is his rehabilitation assistant at home, if she does not understand the safe swallowing strategy and working practices, the whole plan will die the day he was discharged from the hospital. Yeah. So we need to really bring the families as early as possible and avoid jargon, medical terminology, and make the treatment plan very clear. So I will stop here just to see if there are any questions before I progress. Are there any questions? All right. So I will proceed if there are no questions. So yeah, so let me connect this back to the tension we opened with. That is the overlap designed into rehabilitation team. So professionals are expected to coordinate and kind of safely double cover, and they fill the gap when the colleagues is off or a post is empty, right? The danger is not the overlap. So if the physiotherapist is kind of improvising to do the work of the OT because there is no OT in the hospital, it's not a danger or it's just an overlap. The territory is kind of it's not about that is my patient, but rather it's a shared space where we could be able to make the best of what we have to provide care for the patient. And it's not about saying that is my patient. The power struggles we do have in our clinics, in our hospitals, where the doctor will say, "Is my patient," and the other professional will say, "Is his own patient," and stuffs like that, and that results into fragmentation and patient loss. Right, the patient suffers the problem. So I want us to have this one goal, clear lane, and the rehabilitation roadmap as a tool. So on the right, let's turn all of that into something you can kind of actually draw. So let's take this as our first tool, a rehabilitation roadmap. It is called the RACI grid. And do not worry about the jargon. It's just 4 letters, right? For everyday tasks. You name who is accountable. And that is exactly one owner of the outcome. Who is responsible? The people who actually do the work and who is consulted. That is who gives the input before it happens. And who is informed. So who is told after. So let me read to you one rule, right? So safe swallowing, that is speech therapy, is accountable. He's the owner, right? The nurse and the family and the families are responsible. They do it at every meal, right? So the physio is consulted on things like positioning, right? And the OT is informed. So now look at that one row and you can think about yourself. Would that single line drawn in a whiteboard on day one have prevented Mr. Okonko's pneumonia, right? Of course, because then it becomes clear who is accountable for the swallowing issue, who should be consulted, and who should be informed, right? So that exactly one accountable rule is a thing that kills everything, right? So that's something that we can really take into account when we do assess patient, and if we want to really do interdisciplinary collaboration in treating the patient. So here's the same idea about and it's a cascading one into every discipline lane, right? So Mr. Okonkwo's life, that's his goal, to provide for his family. We negotiated with him into one concrete shared goal. Let's say walk to his place of worship unaided and eat safely within 6 weeks. So now let's look at the cascading effect. The physio looks at the gait, the strength, and the balance. The speech therapists look at the swallowing rehabilitation problem and the diet texture. The occupational therapist takes care of the dressing and the route back to work. And the nursing and the family takes care about the daily practice and carryover. So every single one of those lines stresses back to the same goal, right? That's there. Is the difference between an interdisciplinary team and 4 people working in 4 silos. So if everyone is doing his own thing, then it's just like everyone working in silos. So that is a shared goal framework, right? So where does the roles actually meet? If really there is overlap, and if really we want to do an interdisciplinary care for our patient, where does those roles meet at the handoff, right? And knowing where the referral triggers are. So where does rule actually meet? At the handoff are just seams of teamwork, right? Which means seams are exactly where things stay, right? So the skills is spotting the trigger that says this is outside my lane and acting on it very fast, right? So let me give you concrete ones, right? So a cough or a wet, goggly voice when he eats or drinks, that's speech therapy today, right? That is Okonkwo's lessons and bond into a rule. So persistent low mood, hopelessness, that is a psychological problem. We shouldn't say come on, push through, or no, things like that. So issues like no safe home or no income, that is social work problem, right? And that is and it is as clinical as any exercise we will ever prescribe. We should take that into account. And a brace that does not fit into a new amputation, for example, is a problem of the prosthesis and orthosis. And, and because untimely care was one of the leading consequences of poor teamwork, most especially in Nigeria, a kind of fast and clear referral is an antidote to that. I think that should sit with us kind of squarely. So let me give you a feel of the rhythm of a team. So not just its structure. So rehabilitation is a relay race, right? So it's not just a kind of rhythm. So the one person that starts, it's the centered around the patient progress, right? So it's the physician, mostly in most cases, as the first contact, where the medical examinations are done. Then once rehabilitation issues are identified, the first person that the physician thinks about to refer to is normally the physiotherapy. And then the physiotherapy, once understanding the limits of the profession, um, in a situation where there is no need for extension or provision to care for the patient, and there are OTs or speech therapy, issues related to OT and speech therapy are actually relayed back to the speech and speech to the OT and speech therapy. And then, of course, preparing for discharge, definitely carrying over for the patient is normally relayed back to the family members. So it's not just a silo thing. It's just one person passing on to the other person until the patient is discharged back home with his family members. So the silo problem is that I did my part. It's normally what we kind of say. It's not the same thing as doing the job, right? So the trap is that each clinician complete his own task and assume the rest will connect itself. So to fix this, we need to finish every contact every contact of the patient by asking, what is the next team member needing from me? And writing it where they can see it clearly, right? That is what matters. And that is what I meant by relay race, not just a silo approach. So the scope creep erodes the safety and trust. And in Nigeria, it kind of breaks it all. So we have this we have the MRTB law, right? Set by the Decree 38 of 1988, now capped to M9 of the laws of the Federation. I think 2024 license physiotherapies alongside OTs, speech therapies, audiologists, prosthetists, and orthosists, and others, right? So it sets and enforces the scope and credits kind of our training and goes after kind of quackery and unqualified people practicing. So now the scope creeps run into two directions, and both are very dangerous. So one way, you drift into a colleague scope. So if physiotherapy deciding to manage a swallowing problem, that is kind of unsafe and kind of it breeds the conflict, right? But the other way matters just as much, right? Letting an unlicensed aide to do a physiotherapy under your name, right? Kind of handing over your role for someone to do in your name, which is also very harmful. So that harms the patient and it exposes legal problems, right? So knowing your scope precisely is not bureaucracy. It is just a patient safety, and it is our own professional protection, right? Then the third pitfall here is the invisible patient, right? And this is a strange one because it comes from teams getting kind of getting good at this. So a team can become so slick to talk about each other that they end up setting goals about the patient who was never in the room when the decision was made, right? So technically excellent, but humanly irrelevant. So if you think about patient-centeredness, the way to fix this is using the ICF framework. We need to deliberately include the patient owns priority. We do that in our assessment, in our clerkings. We ask patient goals, we set goals, but really centering that around the interdisciplinary care so that the next professional you're passing on the patient to is clear on what you are expecting him to achieve in terms of the patient goals. And that helps a lot. Likewise, the other way around, the professional sending the patient to you, having written it clearly what is expected of you in terms of the patient goals, not telling you what to do, but why is he referring the patient to you in a very clear patient-centered approach really helps the conversation, and that avoids the empty chair problem, right? So pitfall number 4, the hierarchy that silences the person who saw the problem. So the trap here, the physio noticed the unsafe swallowing problem, but felt it wasn't their place to speak around. For example, if the physio recognizes the problem. So the fix is that your scopes gives you the standing, right? So you raise the safety concern regardless of the rank, and you kind of build forums where that can be expected. So it's not about detecting the problem and then if you recognize it's out of your limit to setback, but rather raising the concern. It is what really will help in interdisciplinary collaboration and teams forum. So the rehabilitation roadmap, who is accountable, who is responsible, who should be consulted, and who should be informed. That is a tool I want us to really keep in mind. So for a specific clinical problem, we need to be very clear when managing the patient. We need to name one owner of that specific task. And the buck stop here. So who is responsible for that problem? And who is accountable for that problem? And then who does the hands-on work? It can be several people. It can be several team members. If you think about the problem of mobility, where the physiotherapists handle the physiological limitations of the patient by providing therapy targeted to the disabled or to the impaired physiological entity of the patient, while the OT ensures that it's transferable into daily activities of living, right? So that's a shared responsibility. So who is responsible for that? And then who should be consulted? That is who gives the input before the action. And it could be two-way system. The OT could inform the physiotherapist and the physiotherapist could inform the OT. And that goes bi-directional, right? In this example. And then who should be informed, who should be kept in the loop after the decision is made. So it's not just one silo, physio doing his things, nursing doing his thing, OT doing his things, but really who should be kept informed. So this tool will really make it very clear when we make treatment plans and when we document patient progress in ensuring that we uphold rehabilitation teams forum in our daily practice. So here's the second tool, the scope and the scope lane card. That's where is my lane, where is the shared zone, and where is the other people's lane. So if you take an example of the mobility problem, my lane as a physiotherapist would be around the movement of the patient, about the strength and gait of the patient, about the balance of the patient, and the exercise therapy prescription I will give for the patient, right? That's my lane. Where I shared my lane with other people is a shared zone. Transfers. How does the patient transfer in daily life activities? How does the function of the patient translate into participation? How does the goals of the patient are being coordinated into what the patient expects in terms of his priority? So here I could share it with other professionals, right? Like speech therapy or occupational therapy. And their lane is where the other professionals are on their other side, right? We don't share precisely. So if you think about swallowing problems, is specifically the problem of a speech and language therapist. If you think about daily activities of the living, patient saying, I can't get out of bed, I can't go to work, I can go to church, for example, that is the work of the OT, right? You could achieve much function, much gait, much movement resolvement, much strength and gait problems, much balance improvement. But if the OT is not there to translate that into activities of daily living, then that becomes a problem. So you can see clearly that is a lane for the OT, right? Problems around psychological issues is completely a psychological problem where the psychiatrist or clinical psychologist could handle. Then social problems like finances, discharging home is completely a social worker problem, right? It's not our lane as a physiotherapy, is their lane, right? I'm not trying to segregate, but I'm trying to put the boundary to see where we each stand and where the zone crosspath happen, right? So knowing this really helps to facilitate rehabilitation teams. So the ICF goal alignment worksheet is another tool I want us to take into account. I'll provide this so you can have a copy. Turn the wish into the coordinated tasks. So first is patient on words. Not before any physician, before any clinician impose words into the mouth of the patient. What does the patient actually say? I must provide for my family as an example here of Mr. Okonkwo. Then the ICM framework is participation. That's the level, right? Return to work. That's the main target. And then the shared SMILE goal will be where the professionals really coordinate their therapies in a clear articulated goal. That is, for example, walking 50 meters plus safe swallowing within 6 weeks. And then each lane stacks. That is, who does what for the patient to be able to achieve the SMART goal, right? Physio, speech and language therapists, OT, nursing, family, physicians, name it, all the healthcare professions that could be responsible here. So that's a clear ICF goal alignment worksheet that you can use in your daily practice. Then the referral trigger card. When do I trigger referral? If you see this and then you refer today, right? So it's not about delay. We shouldn't delay refer. We should refer as soon as possible. So let's take example of Mr. Okonkwo here, right? Once we identify cough, wet, and eat problems, is a speech and language therapy problem, right? And referral should be triggered for that. When we see problems with mood and psychological problem, this is a clinical psychology problem. we should trigger psychiatry problem, because I know it's very difficult and rare to have a clinical psychology within our settings, right? That if we see a no safe home problem or income problem, we should think about social work referral or any community services that could help the patient if that is not available in the hospital. Of course, things like limb loss and paralysis problem, it's very clear. We know this is a prosthesis and orthosis problem. New medical instability, we know we have to trigger collaboration with the physician. And if patient can't manage daily life tasks, it's definitely the OT's shared OT's lend, right? But in most cases, we overlap and improvise to handle that. So now, the fifth tool I want us to have is, what is my unique contribution card? What is exactly are you contributing? What only you can tell to the team? That is your own contribution, right? Function. What can the patient physically do today? Is your own contribution. Trajectory. Are there improvement, plateauing, or declining in patient condition? It is your own responsibility. Safety flag. That's why we have the red flags, the yellow flags, and other flags. Any movement risks, the team must know. That is something that we are the only people that can contribute to the team forums, right? Then goal progress, distance to the shared goal in numbers. So it's not just the qualitative odds of the patient, but rather an objective measurement of the goal progress. It is our responsibility to contribute to the team's forum. So every tool here is just a paper tool that you can print and use without having any cost. So pasting it in your workplace or sharing with other staffs will be very useful. So let's reflect in 3 minutes. I want you to map a patient that you have just treated recently and think about, could every team member have stated the same thing, that the same goal, that patient that patient goal that you have addressed? And I want you to draw a quick role map. Which tasks had no clear honor in that case? And was there any referral you saw a need but didn't make it? Or you made it but it didn't work out? This could have been very easy in person. I know online is difficult, but I will leave you with this. When you have this slide, something you could reflect on to see if you can articulate what I've been saying. So the role clarity is something that also I want you to think about. You could use this in your maybe meetings, in clinical meetings, just trying to articulate what you do and what other people could do in the same rehabilitation unit. So we need to be very I want you to also think about this at your next complex, when you have next complex patient to attend to, draw on the role map and name the shared goal out kind of very loud to yourself and the team to see if that could that single act moves your team toward working in parallel to working rather than working as a one. And yeah, it's just a reflection of what I'm saying here. The case of Mr. Okonkwo, if the team have worked as a teams forum, then by 8 weeks, Mr. Okonkwo should be able to achieve the problems. His problems should be able to have been resolved, and he should be able to be back to his desk, providing for his family. But without teams, if every professional would have done his thing differently, then hardly Mr. Okonkwo would be able to return back to work. So I will stop here with the first lecture. Like I said, the aim of this is just to give you a refresher that actually Teams Forum or presenting in Teams Forum is not a soft skill or a nice to have skill. It is actually a clinical skill that is necessary, set by global standard of rehabilitation practice. Are there any questions? Are there any questions? Pardon? Are there any questions?
Yes. Good morning, sir.
Good morning.
Thank you very much for the presentation. It was quite enlightening.
You're
Well,
welcome.
I have a question because you were talking about the gaps that we were meant to fill and how it's supposed to be a patient-centered care.
Yeah.
But then what if you are in a situation whereby there is no gap, instead there is an overlap?
Okay.
Because most of the times practitioners that do this, they don't attend PCP or BCP. They don't come here, so they don't even know where, how to stop, or what the role of the next person is, because they are so focused on performing, let me put it that way, for the hospital to see that they are doing something. So they do your work, they do their work, and in as much as they are trying to do your work, they won't do it the way they should do it. Look, let me give an example. In a hospital where there is no P&O, because I am a P&O.
Yeah.
Now, the hospital decided to employ a P&O person, a prosthetist, because they felt the need to. Now, the person that was handling the whole issue or the whole patient that was coming then for either orthotic devices or any other was the physiotherapist.
Mm-hmm.
Now, it's a little bit difficult telling the physiotherapist to back down a bit or to leave some kind of stuff, because they feel they've been doing it before you came around and they know how this place works. So I don't know, is there a particular way to like talk to that physiotherapist to like move a bit without it being like you are trying to do the work? I don't know how to put it.
Yeah. I haven't catch your name, but really this is a difficult position to be, right? Um, where don't want to step on people's toes, but um, safety really matters, right? Because there is no way a physiotherapist could do the work of piano as accurate as possible because the doctrine of training are different, right? Um, so on the practicalities on how to talk about this with the physiotherapist, I think it really depends on the work culture of the institution. I can give you an example of two instances. First, when I was working in Chicago, um, around my service time, we have an issue of TED stalking. I don't know if you have what you know about that. It's a kind of compression device that is being used for mostly hemiplegic patients where access to rehabilitation on a frequent basis at the acute stage is not available. So preventing things like thromboembolism or things like that, you know. So there's a registrar in internal medicine who happens to be prescribing that even when needed, when it is not needed because it's not as bad as the patient cannot move actually. But he keep repeating the same prescription and it costs a lot because the patient are actually struggling to meet other needs, right? So you can see the idea here is for patient affordability and safety, but also common sense, right? Patient centered. Patient doesn't need that. Why would you prescribe that? And in fact, it's not the role of the registrar to prescribe that because only the physiotherapist can be able to assess the level of impairment in the hemiplegic patient to see whether um, the patient need that instrument or not. The doctrine training is completely different. There is no way a a physician had that training, but rather a physiotherapist had that training. So to communicate that became an issue and it became a conflict on its own because the intent was telling the registrar that, hey, this is not actually what you're supposed to do. We've noticed that on several occasions you prescribe this thing, but the patient actually doesn't need it. So could you please at least inform us before you prescribe? You see, that's a diplomatic way, right? Not saying beforehand, don't prescribe, but could you inform us before you do that? Um, it's a way of saying, uh, ideally, you shouldn't have been doing this without having us uh, involved for the patient-owned interest. But that became an issue. He felt he was superior than anyone, and yeah, it resulted into a conflict that later on he himself was ashamed of what he was doing. So I think if the work culture, I would say, is a one that permits communication with clarity between the professions, the P&O and the physiotherapists, I would recommend approaching them to, in the first place, showing the caveat where the limit is. Because if you don't show the caveat, then they would assume that you're just fighting for a profession, but not in the interest of the patient. But I'm pretty much sure there is no way that is a shared role. It's not a shared role. It's a role for P&O, not a role for physiotherapy. Another way is if there is no that work culture that allows the one-on-one communication, then I think involving um, the leadership becomes very important here. So that could be in form of setting clear roles in terms of what practices, who attends to what for a specific patient. So that will not require you to talk to the physiotherapist directly, but rather taking it to the level where there are authorities that could set that boundary. But having a clear case really helps a lot from my experience, rather than having no case to clear. Ideally, there shouldn't be any reason for presenting examples, right? But because of the nature of the way people think about things in terms of professional boundaries, is always the case that you stand a stronger chance if you make clear caveats, very clear that if this is done, this could go wrong, you know? And I'm sure that will be the case because there is no way physiotherapists, I repeat again, could be having a shared role in terms of doing exactly the work of P&O. I don't know if that helps.
Yes, it does. Thank you.
Yeah, and I think the MRTB could be also a very good platform for you to advocate for that. So at least, by all means, I know all hospitals and facilities, in one way or the other, are accredited by the MRTB, and they would have a contact to be able to address that. Are there any questions? Okay, so if there is no question, I would encourage that we take a break, a 30-minute break, and we return at 5 minutes after 12. Is that okay? Is that okay? Who is the chair leading the session? Okay. All right. So we will take a break and we will return at 12:05, please, for lecture 2. And then we take another break for lecture before we take lecture 3 and 4, which will be quite faster. All right. Have a great break and see you later. All right. We can start. If that's great. Maybe the chair of the session can give a thumbs up when it's okay to start, please. Okay, can we start? If I can get 5 thumbs up, then I think we can agree to start. Right, I can see Mariam. Okay, Najib. Excellent. Yeah. Okay. Uh, let's continue. So this next session, next lecture will be we will move a little bit faster than the first one because the first one I tried to lay the foundation of who does what, right? We try to understand our each person's lane and how the shared role is a true reality, especially in the context of how we practice at home. With limited and constrained environment where we have to improvise every now and then. So that was really very clear. And one key thing I wanted to say is that the key takeaway is that we understand that now rehabilitation is not just an add-on to healthcare services, but it's really central by the World Health Organization and global health policy. So there's a massive shift which hasn't happened for the past 75 years, and it's only happening now, where rehabilitation is put into papers, into policy as a global care provider. So that has shifted the role of rehabilitation team that include all rehabilitation specialists as central to patient care. And one key emphasis on top of that is that for us to achieve a shared rehabilitation goal, we need to have a patient-centered approach where no one takes the stage as a lead of deciding what, but rather the patient themselves. And we all agree that our management and treatments and therapies should be centered around the patient goal using a common language frameworks like international classification of function. So what I want to say in this lecture too is the etiquette. I think that falls back to the question we had before we wrap up the first lecture. How do I really walk in to have conversation around the etiquette of what is shared, what is Teams Forum, right? So what I want to I want us to have clear is that the last lecture is who does what, that is our role and everyone's else. And we mapped the whole rehabilitation team as a single sheet of paper, right? So now what we want to do is something harder. I want you to imagine walking into the room where all those roles actually met, a case conference, a ward round, a Teams meeting, and we ask, how do we behave here so that all the role clarity becomes good care, right? Like the case of the question we had from our colleague, it's about good care. It's not about who does what, but it's hardly to really get people on board to understand that, right? So, because here is more of the uncomfortable truth. A team can have a perfect role clarity on paper, but still fail in the patient room. So the meeting is everyone's else is something the meeting is where the clarity turns into one shared own plan and dissolves into one person talking while the other everyone else has to wait, right? So by the end of this lecture, you would know how to prepare for a meeting, behave in it, speak up in it, and close it. And you will leave with 5 tools that can help you to do that. Again, these are all reminders. We already have them, but we assume they are soft skill rather than a key component of the clinical skill, as much important as the treatment we deliver. That is a key point here. So 4 things. By the end of this hour, 1, you would have you would arrive prepared. You walking into contributions structured and ready to not to improvise, but really structured. Second, you would participate but not speculate. So you would contribute, listen, build on others instead of waiting in silence. 3, you would speak up safely. So you will raise concerns or disagree across ranks, doesn't matter, constructively without any fear. And then 4, the most importantly, how you close the loop, right? You will leave the discussion with decisions made, owned, and understood by everyone, not personal feelings or emotion, but rather professional. So we follow one meeting, right? Before the room, inside the room, the hard moment, and then after. So before, that is, we need to come prepared. During the meeting, we need to be structured and we need to participate. And the hard moment where disagreement happen, we need to speak up and disagree very well. And then after that, we need to close with very decision, right? So the whole hour hangs on one patient case conference, like I did in the first one, not done badly and then done well. So I want us to see how it will happen if it is done badly and then if it is done very well. So here is the idea, the whole conversation, the role clarity is written on paper. The teamwork happens in the room, right? A team can know exactly who does what. We all know this by our training. We know who does what, right? And it still fail in patient, right? Because the meeting is where the clarity either becomes one shared own plan or it dissolves into a single voice where everyone has to listen. The case of physiotherapy, working, doing the work of an OT, of an OP, O&P, while there is an O&P, right? So as an example, real life, we had that, right? So a team can know exactly who does what and still fail. Again, I repeat this because the meeting is where the clarity either becomes a shared one, own plan, or dissolve into a single voice where everyone else has to wait. So I want you to treat the case conference as what it is in reality, a clinical procedure, not an admin one, right? Not a downtime between the real work, right? A procedure with a structure and an output. And I will be honest with you, that the research on team meetings is a mixed one. Simply holding a meeting changes nothing for the patient, right? What changes the outcome is how the meeting is run. And that is how our whole subject will run today, right? So one quick look back. In the previous lecture, we ended with a simple rule. Every team member owes the team 2 questions, 2 answers. What is my role and what is everyone's role? That is a clarity that is necessary, but it's not enough. So knowing your lane is useless if you can't use it well in a meeting, right? So let's step into the room and let's start with the room in its worst case scenario, right? So picture a meeting about Mr. Okonkwo, our patient, right? Our stroke patient from the last session we have. So it's been discussed now in a meeting, and the consultant runs through him, right? Mostly taking the talk himself. That's what happens mostly in workrooms, right? When in case presentations. So the physiotherapist in the room, she knows exactly how far he can transfer, how his balance is. She says nothing. It didn't feel like her place to speak, right? Because the consultant or whoever it is in charge of that patient decide that he's alpha and omega, right? And the nurse is there too. And she saw Mr. Okonkwo who coughs on water that morning. She kept it to herself or to himself. And Mr. Okonkwo, he's on the ward, right? He's not in the meeting at all. It's always the case that if there's a case presentation or a case conference where a patient is being discussed anywhere in the hospital conference room, in the consultant's office, in the physiotherapy office, the patient might not necessarily be there, right? If lucky, in the work rounds, all the team meet, then that's where the patient could be there, right? So he's in his own word. He is not in the meeting at all. So decisions have been made about him without him, right? So now here's what I want you to sit with. Nobody in this room is incompetent. We are all competent, right? Nobody is unkind. We're all kind, right? It's not about personality. Every fact needed to keep him safe is present in that room. All professionals are there. The doctor is there. The physiotherapist is there. The nurse is there, right? The P&O, the OT, if there's speech therapies, they're all there, for example. So, and yet the meeting will turn out to be a failure, right? So how many have kind of sit in that kind of meeting? We've just had a case from one of our colleagues, the P&O, what happened between her and the physiotherapist, the way the dynamics is happening, right? I have seen many in my course of practice, many, many, many. In fact, some of them turning into bureaucratic things like who turns up with more money to the hospital as revenue, right? Gets the better way and better ears to be listening to. And we have to find our way out, and it works. I might share with you how it works with us when I was in Jigawa. So what did that meeting actually produce, right? Let's be precise. There is no owner. Nobody left accountable for unsafe swallowing of the patient. Nobody acted on it. No shared goal. No single goal. Everyone could state. So 4 professionals pulled into 4 directions, right? And a preventable harm. The cough nobody voiced became the aspiration pneumonia I was saying. We talked about it in the last example, in the last session. So notice what didn't go wrong. It wasn't a knowledge gap. Everyone has the knowledge, right? Every fact was in the room. Right? It was a meeting that produced no owner, no goal, no voice concern, which means that the case conference is a safety critical event. The quality of the meeting is the quality of the care, right? So that is worst case scenario that could happen. Just emotional. People talk out, professionals talk out of feeling that I'm confident, I'm competent, not really sharing a common goal of that the patient is the main end game here. It doesn't matter about how much expertise you have, as long as it doesn't translate into the patient quality of life, right? So in our system, the meeting table also carries old rivalries. That's the honest truth. We all know that 70% of healthcare workers in Nigeria, a study was done, and it shows that interprofessional rivalry as a leading cause of conflict in the hospital. So this could be things around salary and status gap between healthcare professionals. How much does the registrar on gets as a salary? How much does the head of department of or P&O or head of department of physiotherapy gets? That comparison of money, how much does someone earn, is still there. Resident doctors still go on strike. Medical lab, for example, or physiotherapy, wanting to upgrade their professional curriculum became a professional rivalry. Doctors saying, no, that cannot happen. You can have this, you can have this. Pharmacy getting their own way because money works. So that kind of thing is still there in our system. It might not be necessarily very pronounced elsewhere, but it's something that really matters in the politics of our profession at home. So, and there's dispute over who leads the healthcare team. We know the status quo is that the physician gets to lead the team, which is not necessarily true because in some places, it's a completely different person that gets to lead the team, which is the business admin, the business people who run the hospital as a money-making machine, not necessarily who is the consultant or who is the most expert surgeon. So that happens. But when it comes to the clinical practice, in the bedside, it's always the case that in our environment, the physician always takes the lead in the team, right? And there is also blood job boundaries and poor communication. Like an example I gave about as simple as TED stocking, a registrar couldn't really identify that his doctoral training does not train him as something that he should do, right? And then the communication gap, the ego that still exists between professionals is something that is really embedded in our system. So for each case conference we're working in, I think we need to have this at the back of the mind that this could be the drivers of people's behavior irrespective of how many qualifications they do have, irrespective of how many years of experience they have, irrespective of their position in the hierarchy of leadership and management in the facility. These things could really drive how they behave. So that is very important. And then the case conference is a clinical procedure, right? So you would never improvise a clinical procedure, right? We don't improvise the meeting that directly. So a procedure has three things, right? And this should be a meeting, right? It has a structure, right? The preparation, who chairs the meeting, what is the agenda, how do we close the meeting? It's not free at all. It has to be structured, right? And then it has an output, right? What is the shared plan that this owned and acted on? So not just a discussion, but what is the main thing we want to achieve? And more people is not equals to better, right? In most cases, the more the room is bigger, the more it becomes harder to decide, right? So a bigger table only helps if the process turns into the talk into action. So real hands-on bedside application. Then where probably the hands-on, the bigger the room, because there might be intent, there might be junior staffs who would actually carry out the procedures and should be there in the meeting, right? So, and then we need to also have this as a foundation, because psychological safety, the belief that speaking up will not get you punished, right? It's a professional, it's a professional tool that one needs to have, right? So, a shared belief that the team is safe for taking interpersonal risks, asking a question, raising a concern, admitting a mistake without the fear of blame or humiliation. So in anything within the physiotherapy team and outside the physiotherapy team or OT team or language therapy team or piano team or nursing team or the entire hospital facility, this should be a work culture that should be there to have a better psychological safety tool to use, right? So why does it come first? Every other skill today, including the ESPER, which I'm going to say, the speaking up, which I'm saying now, this agreeing well, which I'll also show. It only works in a room where people believe it is safe to use them, right? If I believe that speaking up is a problem for me, then it's very hard for me to be able to speak up, right? That is something that it's clear and it makes sense, right? If the S bar is a tool where, which I will show afterward, is not something that is acceptable in a meeting, in a case conference, then I wouldn't feel comfortable using it as a tool to present my patient, right? So the major thing that needs to be there is a psychological safety. And that is a big deal that has to be embedded within the facility work culture. And then the best teams reported more errors, right? Because they are willing to talk about them. So being quiet doesn't really help in much cases, right? You need to speak up. If you don't speak up, then no one will ever know what you're doing. So trying to look calm, trying to report fewer errors, but problems are hidden, but not absent, and they surface afterward because problems do surface all the time afterward. So the quiet team culture is not helpful at all. Irrespective of which profession you are, speaking up, it's something that really helps. Not hiding errors is something that talks about professionality. So a safe team, it's the one that reports more because it's a face problem early, right? And while they can still be fixed, but speaking up is kind of normal in this team, and that is a culture that is necessary within the team to make this work, right? So let me stop let me stop a misunderstanding before it starts. So especially for senior people in the room, psychological safety is not about being soft, right? It is not coddling, right? It is not being nice, avoiding hard truth, lowering standard, or always agreeing. it is a cordon in service of high standards. So honesty, direct, and respectful at all once, right? The formula is kind and clear, not nice and relaxed. I think that's a better way to put that. So in fact, a psychologically safe team holds high standard because people can challenge each other honestly without turning into personal, right? So to the seniors, nobody's asking you to lower your standard or your bar. We're just saying we're asking you to make it safe for people to raise concern about meeting it, right? That's what I want to say here. So how do you actually build it? There's something called Edmondson um, rule that gives three moves. First, the framework. That's a frame the work. So you kind of frame the work, right? Name the stakes and the uncertainty up front. So this one's is kind of complex. I need everyone's eyes here. So second is to invite engagement, right? You name the stakes and uncertainty upfront. That's very clear. And then you engage, you invite engagement, ask real questions, and ask quieter members directly. You are not kind of, what are you missing? Like, why are people quiet, right? And then we have to respond productively, right? Thank the person and act on what they raised. And then punishing kind of conduct skills, punishing conduct kind of kills it if it is good. So what I'm trying to say here is that these are three moves that makes the room safe. So frame the work, that name exactly what is the stakes people are talking about, invite them to engage and respond productively by acknowledging what they say. So before the room, that's because here's the thing, most of the quality of a meeting is decided before anyone sits down, right? By who prepared and who didn't, right? So good meetings are won before they began. So we need to prepare first. And then walk in knowing the four things only you can report, right? And in this case, is if you refer to the first session we had, your unique contributions, I call them, they're your tickets to speak in a case conference. Prepare it and do not improvise it at the spot. Get it prepared before you go into the meeting. What is the current function? That is where the patient is now. Trajectory, clearly improvement, plateauing, or declining. Where does the patient stand? Safety flag, that is any movement related risks, and then goal progress against the shared rule. So you benchmark what has been said against where the patient is right now in numbers, not in arbitrary words. So the tool that will help one to do that is called the SBAR. It turns everything you know into four CRIPS lines, right? The situation stands for S, the background stands for, the B stand for the background, A stand for assessment, and R stand for recommendation. In our case of Mr. Okonkwo, the headline now is Mr. Okonkwo D5 post-stroke. So I'm concerned about his swallowing issue. The background, which is the relevant history, is that he's right hemiplegic, dysphagia, physio is in progress, and there is no formal speech and language therapies review yet. And the assessment, what you think is that I think he's at aspiration risk and his goal isn't agreed. Recommendation is what you want. Can we get a speech and language therapist review today and set a shared goal? Very clear and direct, using this four tool to make it very clear. And this is evidence-based because in a teaching hospital, from a study somewhere in Sudan, in Khartoum, they reported how this differs before people were using the SBAR and after people started using the SBAR. And they audited how completely staff used the SBAR in handovers, right? Before they transfer the patient from one professional to the other. How do they really use that SBAR? Simple logic that we might be already using it in our clerking, in our documentations, but it hasn't been something that has been standardized, right? So at the baseline, the situation element was filled without 7% 90% of the time, and the other part near zero. So then they run 1 week of training. After that, the completeness of the situation jumped to nearly 90%. That's how people really complete the situation. And the other element rose almost nothing, right? So 1 week, and now no new technology, it's just simple paper and pen thing, right? And the lesson is simple. This is cheap, this is fast, and it works in our context as well. It needs training and habit, but it's kind of a very good thing. If you transfer a patient, or you're presenting in a case conference, this is really something that will help to make it very clear. So starting late and unprepared tax this scarcest resources we have initially. So when we walk into meetings, we have to walk in on time and we need to end on time. And if we start late, it wastes the combined time of every professional in the room. And that have a multiplied effect. Maybe the time that we would have supposed to be used by the nurse to see the patient is wasted in the meeting. So come with the expert ready, reading your notes for the first time in the meeting steals every 1 minute. So you have to prepare beforehand. It's something that we have already passed through trainings, and we do this over and over again. So having it prepared beforehand saves a lot of effort. So in the room, structure is what turns the talk into a plan. So we need to have a structure, and the structure could be very effective when the meeting has one, that is a named chair. Is the difference between a discussion and decision. For every meeting, there needs to be a chair who leads the meeting. If the meeting is led by a designated person, the collaboration is better and the decision is sharp, right? Someone must own the room. So the agenda keeps that, right? One patient, one goal, one clear order, and the time is limited, right? And that draws everyone in. So you need to invite everyone to speak, even the quiet expert by their name. So stop one voice dominating, right? You need to make sure everyone has contributed to the meeting and the shared goal of the patient. And we need to close each item, right? So we need to name the decision that was taken. We need to know the owner of the decision. And we need to set a deadline before moving forward, right? We've seen that in the first session with the tool on how to do that. So we need to be clear on what is the meeting actually about. So keeping the patient and one shared goal at the center of the table. That is a point about patient-centered care, right? We need to invite the patient voice by either having the word round bedside or having the patient voice documented exactly and their goal. And we need to decide with and not about. We need to use the patient goal as a goal for the treatment, not about the patient, but not about the goal, but with the goal, right? And then we need to agree on one goal first. So it shouldn't be blurred. It should be direct goal setting. And then we should confirm before closing that everyone is clear on that. That could be in what rounds, that would be in the case conference, depending on what name and what environment is being used in such cases in your facility. And silence is not humility, right? Wait and see in the meeting harms the patient, right? If there is something you have, you kind of contribute because you're holding a data, and if you don't talk about it, you hold until you're being asked, then the evidence is that passive members hamper collaboration and they weaken the plan. So even within a departmental meeting, holding a data harms the progress of the patient that are being cared for. You need to be able to come forward and talk for the patient, right? And then active contribution offers you have to use tools to make it very clear. And you have to accept responsibility for your part and engage with the chair and the plan. So the other half of the communication is listen to build, not to wait for your turn, right? It's not about waiting for my turn to talk. It's about listening and then to build on top of the conversation. So one conversation, there is no side talk, there is no phones. The room listens to one voice at a time. And then you have to build on others, right? Reference what other last person has said and connect with your point with theirs. That makes the conversation move forward. And then make a room. Notice who hasn't spoken and open the space for them to speak. That really helps in patient management. And then make sure that the message landed very clear. So close the loop, say it, repeat it back, and confirm it. So call it out. the sender states the decision or request clearly. So you need to call it out. Like, for example, speech therapy review for Mr. Okonkwo needs to be done today. Speech therapy review for him today. I will call it now. And then you acknowledge that. So kind of seeing it very clear to the room, and it's been accepted on what is being decided on. I'm using the case of speech language therapy here and Mr. Okonkwo just as a case example, but there are many different cases where this could be applied interprofessionally. So we need to check back just to make sure that the person responsible is clear on what is expected, right? And they say it in their own words. And then we need to confirm that to close the loop and agree before the meeting is closed. And the reading of a working team is planned before, adjusted during the meeting, review after the meeting, brief and huddle, and then debrief, right? So brief before the meeting, share the plan and the goal in 2 minutes, very clear. And then during the meeting, a quick stand up to adjust when things are changed. So when the set plans are not exactly as expected, then the plan has to be adjusted to the reality of the conversation on ground. And then there needs to be a debriefing. What went well, what to do better, and the blame free. It's not about pointing fingers. So in a busy ward, this is often a 5-minute stand up around the whiteboard, right? No room booking required. So it's just something that we do bedside with the other professionals and have conversation around the patient. So the hard moment is speaking up and disagreeing well, right? That's the hard part. So when something is wrong, we need to escalate them in 3 calm steps, right? That is called the CUS, right? Am I concerned? Name it early and quietly if you're really concerned. Am I uncomfortable? Raise the signal if unheard. Is this a safety issue? Stop the line, and it must be addressed. So in an order of escalation, right? If you're concerned, name it clearly, name it early and quietly. If you're not comfortable, check if they signal that everyone understand that you're unheard, there is something uncomfortable. And if there's a safety issue, I think you need to stop the line and it must be addressed. So for the question we had about the P&O and the physiotherapist, I think this is a very good tool. What is it exactly the situation the colleague is in? So if it's about concern, it needs to be raised. If it is about uncomfortable, that needs to be signaled because clearly the PT probably may not have acknowledged that. And then if it is a safety issue, patient life is online, so that has to be taken, right? There needs to be a stop line and it needs to be addressed with the measures that are necessary available. So breaking the silence in the right way. So the 2-sentence intervention that turns a worry into an action, right? If you have something that you worry about, I think this tool is something that really turns it into a worry, from a worry into an action. So state the concern and then offer the solution. For example, hey, doctor, I'm worried he may aspirate. I'm talking about Mr. Okonkwo, who has difficulty swallowing. Can we get a swallow review before we start oral feeding? You can see you raise the concern clearly, very short and concise, and you provide the solution. And then that way the actions becomes very clear. But if we just stop at saying, I'm worried he might aspirate, then we leave the room open for speculation, right? So why does it matter, right? Failing to speak up has been found again and again to be the primary contributor to clinical errors, right? The silence in itself is a hazard. So we need to speak up. So when you genuinely disagree, what happens? That is, disagree without a fight. That's the best case, right? Describe, express, suggest, and consequences, right? So if there's a disagreement, the ultimate goal is to avoid a fight. So the first thing is to describe this specific situation factually. For example, the plan is to have him on a normal diet. That is a specific situation. I'm talking about Mr. Okonkwo in this case, who has swallowing problem. And express your concern. I am worried that he's unsafe given his swallowing issue, right? Now you express your concern. You have the fact, which everyone agrees on, this patient needs to be on a normal diet. But here's your concern that you're worried this patient has safety issue, that there's there's a safety issue here. And then suggest an alternative, right? Could we hold an oral feeding pending speech and language therapy review? And then frame the consequences around the patient, right? That way we can avoid aspiration setback. So you can see you're not just doing one thing at the same time, you're being pragmatic. And for any professional who listens to you speak in just less than a fraction of a second, knows exactly this is professionalism. It's not about fighting. It's about the fact, it's about what you've seen as a professional, it's about you offering solution and you offering what could have happened from your own lenses. So that way, it's not about fight, but it's about fact and then the way forward. And then the move that kind of diffuses rivalry at all. So argue about the patient goal, never about whose patient is it. So never about this is my patient or this is what I'm supposed to do for this patient, but rather being not positional but goal centered, right? That could be that's my decision to make. If you're taking a position, which is very bad, right? That kind of, if you say that's my decision, for example, then it turns the table into territory, right? That's the rivalry trap. So then the other person will feel that, oh, he's defending a kind of boundary that he thinks I cannot cross. And then the issue of whose training is perceived to be more broader becomes interplay, right? And then the way out here is to be goal centered. What gets him eating safely fast? That is, now you're talking about the patient. So your concern or your decision is about what gets the patient to eat quickly, safely, and fast, right? So it puts the goal on the table, not just you, but for everyone, because everyone can join. As long as that the patient is a concern of every healthcare professional in that facility attending to him, then you all agree on that this patient requires to be able to eat and be able to do that safely, right? So that takes out the rivalry issue here. Is that a question? Okay, so if that person can unmute, that would be great. So the written rules and our room, right? So the small courtesy carry a big signal. Respect your room and make rank safe, right? So be present. As small as fun should be away, no side talk. Attention is the basic courtesy. So there is no way you're walking into a case conference or any meeting or word rounds and you begin to swap your phone or you begin to chat a colleague from the side and you lose attention, then there's no way the other person will respect what you say. That's the reality, right? So this is a basic thing that we all are aware. It's just a reminder that what makes a big difference, right? It's just a small courtesy, but it carries a big signal. And then confidentiality matters a lot. What is discussed about the patient stays within the team without any spillover, except if necessary. That is also something that matters a lot. They are not written, right? Nowhere it is written that you shouldn't do this, but knowing them, walking into the room with them, I think that carries a big signal, right? And then plain and shared language. Avoid jargon. We all have our doctoral language. When a physiotherapist speaks, if he wants, he can speak for a minute without the nurse understanding what he's saying. And likewise, the nurse or the physician or the PNO or everyone has his own jargon, right? So what matters most is when we speak, we should be able to speak as plain as possible. Because if you say something thinking that being too technical, being too professional with the technical jargons that we use in our domains will help. I think that's not true because then people don't understand. And what's the point if people don't understand what you say, right? Or they misunderstood what you say, right? So agree on the common working language is something that should be very, very important. And on seniority, respect titles without being silenced by them. So you don't care about title, right? You don't care about this is a consultant or not. What matters most is the patient in front of you. And genius use a script. Like seniors invite quiet people to talk and welcome and kind of that welcomes and everyone feels safe in the room, right? So how meetings fall. This is something very important. The monologue and the silent expert, right? So there is a monologue. One senior whose voice fills the entire room. Others stop contributing, and the team's knowledge is just wasted, right? The best thing to fix this is the chair invite others to name by their name, use the expert tool when the gap opens, right? And then the silent expert, the kind of person that hold the one fact that matters and keep it to himself or to herself. So the kind of person that doesn't really speak up, doesn't share the data, right? And to fix that, if you know it, you need to say it, right? And the SU and the CSU that I just gave gives you the word, the easiest way on how to convey what you have, right? That's an important tool if one is that type of person that find it very hard to talk, right? So the second reason why meeting falls apart is the ownerless decision and the absent patient, right? Again, the meeting agrees on something, but no one is named to do it. It just quietly never happens, right? Be it in the bedside. To close this, every item with a name and a deadline is very, very important. Like I said in the first lecture, once a goal is set, it should be very clear before you leave the bedside, before you leave the office, before you leave the conference room, who does what, right? That is very important. That solves the problem of ownerless decision. And then the absent patient, decision made about a person who was never asked, right? Technically right, humanly wrong. You discuss about a patient, but never his voice in it. You could use all your technicalities and all your expertise, but if it doesn't translate into the patient's life, it's just a wasted effort. He wouldn't adhere to any therapy. That's the point. So to fix that, we need to invite them, their family members, to confirm on the goals. That could be done on the bedside as well. So the case conference for the cheers and for anyone, the case conference run sheet keeps a meeting on the rails, right? So this is a 5-step run sheet that I put forward to. So state the patient and the one shared goal. There is no mix up. One after the other. What is the shared goal? Second, each discipline should have this 30-second SPAR in a bedside or in a departmental meetings or whatever venue it is being used. Then agree on changes to the plan, name the owner, set the deadline for that person, confirm that very loud. Words said are much better than just being silent, and close the loop, right? 5 steps that works. And why does it work? It builds the goal, right? The SPAR becomes very clear what is communicated, and the owner and the loop are closed very well. And the 4 pitfalls cannot survive it, right? So you can draw it on a whiteboard in the department or in the nursing station board, whatever it is, and it doesn't need energy, it doesn't need electricity, something that we can document in patient file and so on. So for every team member who is not the chair, the SBIR preparation card, it's very important to fill in before you walk into the meeting. And I repeat again, it's just the situation, the background, the assessment, and the recommendation. What is it exactly you want people to do? And then the graded assessment card, put the words into your pocket, right? I am concerned or I'm uncomfortable, and this is a safety issue. Once you know that, start early and quietly. So the first level is gentle, use it sooner, and then it feels necessary, right? And then escalate if it is on hard, right? Each level raises the signal. So the third must be triggered, must be a trigger and a pause, right? If there's a safety issue, it should be really signaled and triggered. So the fourth tool I want to contribute here is the DESC script. It keeps a disagreement clinical, not personal, right? There's nothing about being personal. It just helps to make the conversation and the documentation blame-free. So it's just a clinical disagreement that do happen in clinical practice, but no one takes it personal. If you use it, that makes it much easier. You describe the fact without any blame. You express the concern without owning it, not saying I, we, that kind of territorial language, but expressing it as a concern, owning the concern, and then suggesting an alternative route without just leaving it blank to the person to eat it up. And then stating the consequences. So that closes the loop entirely. And an example here. So if you look at it here, okay, let's take the fifth tool. So the decision actually happens. The decision and action log gives a very decision. It gives every decision a name and a deadline. So for example, if you have the speech therapy swallow review issue, right? The owner is clearly the SLT, and by when it should be addressed. Very clear. Today, confirmed or unconfirmed. Agree on a shared goal. Who is to do what? The chair and the patient. This, and then by when, within that same ward round, is it confirmed or not? And then are the family taught safety feeding, for example? Who owns it? Is it the nursing? Of course. When before discharge? Is it confirmed if the patient is still in the ward? Not yet confirmed. So this is just a clear kind of example, simple chat that can be put in the department or in the ward round board or on the patient documentation just to avoid professional problems. So no item leaves the meeting without an owner. That's the first rule. Second, the date and a closed loop, right? This is where the four pitfalls will go to die. I mean, they will die off completely. So every tool is a cat and a whiteboard. So there is no need for any computer. It's just something that can survive 5 minute word round, something that can be documented on the patient case note. And it works when even there is no much stuff, because writing a sentence that is just 3 or 4 lines that saves you completely from having a professional problem with other colleagues helps a lot. So reflections, and we close this. I just wanted to have this at the end of any case conference, right? Who in that room had something useful and stayed silent? That is, before you walk into any meeting, what was the previous meeting like? Try to have that at the back of the mind. Who in that room had something useful but stayed silent? Did every decision leave with a named owner and a deadline? That is clarity. Was the patient own goals actually stated out loud? Very clear. That is about precision. So um, it's very important to keep these two things in mind. If there is anything you would forget, this should not be the two things. So we need to give um, priority to the ESPER, and we need to give priority to the CSU to avoid the professional problems and then bring clarity in the conversation. Um, in a good meeting is kind of prepared, safe, structured, and close. This is just trying to wrap up what I'm saying. We need to prepare, we need to give it a structure, we need to make it safe, and we need to close it. I hope that reminds us on what is very important. Um, so, and then thinking about next meeting, it's just an iteration of what the ESPER and the CSU has been applied in the previous meeting and moving it forward. And then if, for example, um, the, the case of Mr. Okonkwo, this rule is applied, then you would see the entire team playing the relay game I was saying in the first lecture, handing over from the chair to the physiotherapist to whatever professional, to the nurses, and then to the patient. And then that cycles back until the patient is discharged and then discharged with his own goal achieved. But if it doesn't work out that way, then we will see isolated, fragmented care without achieving the patient goal. So I will leave this with the materials so you can have a look at it at your convenience. Are there any questions? And then we would have the last part of the talk. Are there any questions? I will stop sharing just to hear if there are any questions. Are there any questions? Are there any questions? All right. Thank you, Samuel, for dropping the message. But if there's any question, you can still bring it up or any contribution. Like I said, this is not about me speaking, but it's we sharing our experiences as well, because context really matters, right? What happens in one place might be very useful in addressing problem in another place. And there is no book that could really guide the context of what is happening in our environment because there's a lot of constraint, which makes it easy to slip into Teams forum issue without having an institutionalized way of solving it. Okay.
Sorry, hand is up here.
Sorry?
Someone's hand is up here. Someone's hand is up.
Okay.
Georgina Chamaka.
Okay, I cannot
Sir.
see it, please. You can just unmute your mic and speak.
Okay, good afternoon. And it's me
Okay.
again, Georgina.
Okay.
So in as much as I didn't want to say anything at first, but when you said it was supposed to be the context matters and we're supposed to speak up sometimes, it's beautiful to have programs like this. But in the actual sense, when you want to put it into practice, it doesn't usually come up like this. In some places, if you talk about things and you complain, you are seen as a problem. And they'll let you go. Which means when people see issues, we don't talk about it. We just say, okay, we'll find somewhere else to go to. So we start putting out open to jobs and just leave that space to just go somewhere else that have very good management and every other. So I don't know how it will be for us to, I'm using myself now as an example. I've attended some CPDs, I have some workshops and the rest, and then it's very difficult to actually implement it because it is not really implementable in places of work. You can't expect, I'm using myself now, my setting. You can't expect someone in a junior role to just talk to the registrar and say, okay, you know what, why don't you involve me? No, they won't answer you. You are not up to the level to talk to them based on experience, academic or any other. So they just look down on you. So I just feel maybe you can tell us how it will fit for us. That's we that are not up to, that can't just walk in to see the MD and say, okay, this is what I think, or go and see the clinical director, because those are high people from where I am coming from. So it's difficult to actually implement all this, even talking about the meetings, talking about how there should be someone. We don't have that power to say, okay, let there be someone to cover for the meeting, a speaker. No, you are just invited to just come and listen and go. I don't know if you understand where I'm coming from.
Yes, I absolutely understand, Shashina, what you said. Before I offered you what I think could be a solution is could you give me an example of how someone or from your experience, someone has attempted to change and that has caused a problem? If you have such an experience.
Okay, so like I said, working in a space where there have not been an orthotist. So
Okay.
you are new orthotist there.
Okay.
From the outside, it's very easy to say, okay, a patient that has, let me say, a deformity. Let me just use pes planus, for example.
Yeah.
For therapists, the first thing that comes to their mind is just put an insole to there.
Yeah.
And then for us, because we don't just say for all cases of pes planus, you should use this.
Yeah.
There have to be evaluations from our side. There have to be checks. There are some tools we also use to determine what type, where is it coming from? Does it pain? Where does the pain radiate to? So that you can actively manage the situation. But when you are trying to say, okay, they are telling you that this patient is our old patient, and this is what we used to give to this patient. So because the patient is coming in for a fit, the size, the fit complaint, let's just change the fit and give the patient what we always give to this patient.
Yeah.
And then because you are new, you can't just say, okay, I want to stand my ground or something like that.
Okay. So in that situation, does the senior ones have the capability to at least have a chat with the people doing that? Just for me to understand the context.
I
So
think
if the new OT do not have that chance, which I absolutely agree with you, in most places that would be the case, right? But does the senior ones have that kind of relationship with those people, managing the patient that way, to be able to have a word with them?
I think it's very easy to have words with them, but
Mhm.
I have taken my time to, like, let's say, talk to OT first
Yeah.
before talking to PT.
Mhm.
But then it's like the PT and the OT are friends. I don't know how to put it. So it's not like, okay, you have said this. Okay, no, it is. When the patient comes, they still do what they want to do.
Well, yeah, I kind of understand exactly where you're coming from. So I think that is reality in most cases, Chichena. Like, two things compound here. One, there's a problem of hierarchy in terms of depth and breadth of curriculum, right? Some professions feel like we have an overarching knowledge about certain things that we can act and cross boundaries, right? And secondly, there's a problem of um, um, there's a problem of uh, that individual and stuff. So at what level are you to be able to speak up, right? Someone coming in new would never be as someone who have stayed there and have the security to be able to speak up, right? So these are things that compound, and they're the reality. I'm really acknowledging that that's the reality. In almost every case, that would be the mentality of which people behave. And if you look at it in the beginning of the conversation, I've laid out about 3 points where in our specific context, it turns out to be even more pronounced. Things around the salary issue because I earn higher, so I'm the bigger, things around my profession is the best, things around um, owning the patient. So I think in reality, to translate these problems should be in steps, like I put forward. Um, if it is something that you're concerned about, then flagging that out using the appropriate channel, even if it means the documentation you write, um, using that as a means to communicate what are your concerns about that patient, what are you not comfortable, in a professional way, using the SBAR tool I provided. It's just not long story in a patient case file. It's just few lines, but really doing the work of not just uh, what you are concerned about or what are your worries, but what could be the solution, alternative solution, and what could be the consequences for that patient. Not you at all, but centered around the patient. If you are centered around the patient, it's very, very tricky for someone to attack you directly because you're not setting boundary for yourself. You're setting the lens on the patient. I understand it could be complex in reality, but starting as simple as the documentation will help a lot. Then I think escalating if there are if there are concerns that really matters. That's where I think getting to the level of speaking up will help if it is done appropriately. Again, using the principles of it's not about your profession. It's not about um, it's not about uh, who does word boundaries. It's about what is the patient need at that particular time. So if you frame the language, it helps a lot. And then if it is about consequences, a patient is about to lose an organ, a patient is about to suffer a lifetime disability because of what is done, then I think escalating it becomes necessary in this case. And that could mean not necessarily you doing it as a junior, but liaising with someone at the superior end who has the security to be able to talk about things, to really talk about that, rather than confronting the other professional top hierarchy to have conversation around that. But see, I can give you this example. And that's why I was asking about the context. We used to have this problem in where I practice, where um, um, patient with musculoskeletal problems um, have been prescribed NSAID like forever. Like forever. Every single problem is just NSAID. Every single problem is just NSAID. Things that are even not related to any pathological, uh, I mean, any microbial pathological pathway, but rather really mechanical that could be solved. Either way, the patient would be subjected to never-ending antibiotic and NSAIDs prescriptions, sometimes even high-level prescriptions as opiates, which is not needed. So you can see there's a tradition that has been there for so long, and it's very hard for us, the new interns, the new employees, to be able to change that. Changing that means maybe harming our own job, being not in good terms with the management. But we spoke in a language that the management understood, because they understood money much better. When you talk about money, that's where the ears listen. And in most cases, even the departmental rivalry, who does what, comes from who generate more revenue. So and then we did something at that time. Instead of going individually, uh, we went as a group of society of at that time, I was part of the Nigerian Society of Physiotherapy in the state chapter. So we advocated for a hospital visit along the entire states, using the funding we have from like kind of licensing and other stuff, that conferences, and then we use that resources to be able to move around the hospital, which in the first place, it brings about visibility. What we realize is that almost most of the consultants have no knowledge of that issue we were trying to address, right? They never know that physiotherapy could able do something to address that issue, because they have a totally different mindset about what the physiotherapy could be. And it's not their problem. It's not something that they created. It's because their curriculum doesn't prepare them for that, right? It just centered them around what they should know, but not what other professionals do in a broader sense. So they actually don't know. And it's easier if they're willing to know than if they're not even willing to know. So the harder ones, honestly, is very hard to deal with them. But the softer ones who are open-minded, the MDs who have that professional mindset, it was very easy to have conversation with them. And within very short time, we were able to turn over those kind of GOPD management of musculoskeletal issue completely back to the physiotherapy department. And that means more revenue from the physiotherapy department. And that kind of cascaded into even allocating budget for consumables for the department. And that kind of gave a lot of leverage. Then the departments and the people in other hospitals were able to speak around the profession to create awareness and address for the minor problems that they face interprofessionally. So I'm kind of giving a broader picture. Hello? So I'm kind of giving a broader picture, because sometimes confronting it as an individual would not work, but rather confronting it as a group works much better. And it takes time, honestly. It doesn't happen just in one conversation. Sometimes it takes longer time for this to be able to achieve. So I think I wouldn't advise quitting the job, but I would advise taking the steps step by step. And having a toxic environment is a completely different thing. I wouldn't say stay in a toxic environment. It's not good for your health, right? If there's option to switch somewhere better, it's always better to switch. But doing the little you could do with the time you're there would be much better. I'm not sure if that was helpful.
Yes, it was helpful. Just that I have switched already.
Oh, you've switched. Well, that's a good move. It's good to switch. All right. Are there any questions? If not, I want to quickly just take next 45 minutes to wrap up the last part of the session. If you want me to take to have, if you want us to have a break, let me know. If not, I can quickly move into the next one. So I will continue. Let me see if I can get the slide. Yeah, can you see my screen? Just a thumb up, that would be very helpful. Yeah, can someone give me a thumbs up, please, if you can see the screen? Yes, thank you. Thank you, Chiamaka. All right. So yeah, the last part of the meeting of the session is what are the effective strategies for communication in rehabilitation teams, right? Some of which we've already talked about in the previous session and during the Q&A session. I will talk about the strategies for effective communication and then digital literacy as part of the lecture, the last lecture here. So the digital literacy will be about how do we utilize the current digital tools to be able to have effective Teams forum. But the second to the last part is just about how do we communicate effectively, right? The three things I want us to take away from this is clear, effective presentation of information in Teams forum. Using patient update, assessment, progress report, and you can name other things. How to address challenges specific to interdisciplinary rehabilitation team. What are the legal and ethical considerations in Nigerian specific contexts, such as patient data sharing, secure use of technology, especially relevant if meetings are virtual, and then exploring strategies and tools to improve teams communication. So I want us to take a hypothetical example of another patient here. I call him Mr. Abdul, right? I would narrate the problem of Mr. Abdul, assuming we are in a Teams meeting. It could be a ward room, it could be a case conference, it could be whatever scenario it is in your own hospitals, right? So I just want you to imagine that situation, and I'm presenting to you, and you are probably this physician chairing the meeting, or the physiotherapist, or the OT, or PNO, or speech and language therapist that is chairing that meeting. I will speak about Mr. Abdul in three ways, and I will ask you one simple question after that, right? The first approach is I will talk to you about Mr. Abdul. Mr. Abdul is a 60-year-old man. He is 6 weeks post-stroke. New challenge of Mr. Abdul is that he has a balance problem, and he nearly falls during 2 times during therapy. He has right-sided weakness. He was walking 5 meters with quadricane, stable blood pressure, and new sedative at night for insomnia. Right side limb strength decreased from 3 to 5, and dizziness in the morning. He has his cognition is intact, and possible medication side effect versus inner issue problem. My recommendation is we should pause the sedative, use GET belt. We need to invite occupational therapy for home safety check. We need to ask the physician here to check the medication and review it. And possibly we need to refer to ENT. That is the first way I tell you about Mr. Abdul. Now think about it. If I speak about Mr. Abdul, the second way, that's approach 2. Last week, Mr. Abdul was confidently walking 5 meters with his cane. Over the past few days, something has changed. He stumbles almost twice in the therapy, and he says he feels dizzy in the morning. His wife also noticed he seems groggy. Testing shows his leg is weaker, and I realized he was started on a sedative at night. I'm worried about his safety. I'm already using a GET belt to prevent falls, but I would like your input. So, Dr. Obi, could you review his medication? And Kemi, who is the occupational therapist, can you do a home safety visit, please? That might help. And if needed, maybe the ENT can check his inner ear problem, if there's inner ear problem. So for now, the priority is keeping him safe while we work this out. That's the second way. The last way, I want to talk to you about Mr. Abdul. Again, last one. Last week, Mr. Abdul was confidently walking 5 meters with his cane, and his wife was really thrilled. But in the past few days, something has shifted. He nearly fell twice in the therapy and now feels dizzy in the morning. His right-sided weakness, he has right-sided weakness, and until now he had been stable. He was recently started on sedative at night. Today, his right limb strength has slipped a grade from 4 to 3 over 5, and he seemed dizzy. I suspect that the medication may be playing a role, but an inner ear issue isn't ruled out. So for now, I'm using a GET belt for all mobility. Dr. B, could you review his medications? Kemi, could maybe a home safety visit, if needed, we could invite the ENT. That's where we are. And what do you all think is the safest next step for him? I've spoken about the same patient in 3 different ways. Which one resonates with you the best? Approach A, that one, approach 2, or approach 3? I want you to put in the comment section, in the chat session, just if you think 1 is the best, if you think 2 is the best, just put 2. If 1, just put 1. If you feel 3 is the best, just type 3. If you feel a combination of any of these 2 is the best, just type 4 in the chat. And the first person that put something closer to what could be appropriate, I would give him a gift, a mobile credit, just little one to recharge your phone. So I repeat again, 1, 2, 3, or 4. If you think a combination is best, a combination is best. 1. Okay, I would be generous here. So I will take the first 3 people. I can see Georgiana said 3, Najib said 2 and 3, Oluwasiu said, Mary said 1 and 2, Georgia, you change your mind to 1 and 3, Esther 1 and 3, Chinenye approach 3, Najib said you change your mind to 4. Okay, probably because I said a combination should be 4, right? Yeah. So yeah, let me take this so that I don't forget. So the 3 answers I will take. So I will stop here and then I will take the 3 people. Okay. Yeah. So here's the thing. Neither of the approach is a perfect one. No 1, no 2, no 3. Neither is a perfect one. And I will see why. The best approach is to combine, right? Is to combine any of the 3 to make a strong presentation about the patient. And here is why. And I think for that, I would say Najib would have my gift. Najib will have my gift. Georgiana will have my gift. And yeah, was it Oluwasiu Mary or Esther who came first? Okay, Oluwasiu Mary 118. Well, you all chatted at the same minute, so there isn't any big difference. So I will take Najib, I will take Georgiana, and I will take Esther, and yeah, the 3 of you. So I will send you a gift to MRTV, and they will reach out to you with their gift. All right. It's just a mobile data that you can recharge your phone. So yeah. So the first approach is just like a very structured approach, right? This is something you would write in a patient case note, but not necessarily something you would say in 1 or 2 minutes, and everyone in the room will understand what you're trying to say, because it's too focused. without any patient voice in it. And it's just matter of fact, right? One after the other. That's the weakness. The positive side of it is that it is very, very clear, right? The numbers doesn't lie. The numbers are very clear, right? What you're trying to see for each issue here. That is the strength of that. Approach 2, it has the human feeling, because I didn't say something that I just observed alone, but I said what his wife has noticed, right? I made it very clear. His wife has noticed he seems to be groggy, right? So I'm taking the patient-centered approach here, right? And then the third, and the strength here is that I have the patient-centered approach, but I lose the precision because I haven't mentioned the values precisely here. It's just a narrative without any objective measurement. So what am I saying if I say he's dizzy? What am I saying if I say he's weak, right? Because we professionals would like to have numbers because that's the way our brain thinks, right? So then the third one is a very good one as well because it combines the strength of the 1 and 2. It used the patient-centered approach in some way because I said exactly what Mr. Abdul was experiencing. He was very confident walking for 5 meters with his cane, and then his wife was also very happy because the progress was very clear. And then I said what I observed in the past few days, right? But then I also used the SBAR format to really communicate clearly what are my concerns and what are the alternative solutions. I invited the contribution of the OT. I invited the contribution of the person prescribing the sedative, and I invited the possibility of referral to ENT. Probably is a vestibular problem, right? So, and then I have some numbers there, which are a little bit adding clarity to what I'm trying to say. So you can see approach 3 could sound as the best, right? But again, if you look at approach 3, it's not as precise as approach 1. It misses things like the blood pressure, right? It's not there. It misses things like what exactly kind of walking aid is Mr. Abdul using, right? So it became loose. All those slip into the narrative, but not very clear in that. So the best approach is to combine the 1 or 2 or even 3 of the approaches to have a very coherent a very coherent narrative when you talk about it. So the take-home message here, if there's one thing I want you to take away here, is that in a Teams conference, in a Teams case presentation, case conference with a bedside, or any rehabilitation Teams meeting, the best presenters are the storytellers who are also structured, right? Those are the people that, whether someone will like them or not, as they speak, they listen. You just have to listen to them because they are very professional in the way they speak. Nothing about the way they feel or their emotions, really centered about the patient, exactly into the patient voice, and also being objective. That is the medical doctrine, right? Being precise. So they bring the patient alive in the conversation, but never lose the precision the team needs to act on it. What I mean by that is they bring out the numbers clearly, but they never lose the patient in the conversation. So the structure, that is the clarity, safety, and completeness, plus the story, which include the engagement, the patient voice, and the collaboration. When you blend them together, they become a structured storytelling. And they are clear and human. They engage the team, and it builds trust and better decision, right? Because you're not centering yourself, you're centering the patient here. And you're not being too professional while neglecting the patient's life, right? So you don't choose, you kind of blend the structure with a story for effective rehabilitation team communication. And the tool I mentioned earlier is the SBAR, nothing new. First is the situation. You identify the situation, the person exactly, the individual precisely, the symptoms, the severity, and any assessment very precisely, the background, exactly when those things happen, time of admission, date of the admission, admitting diagnosis, relevant medical history that are relevant to the conversation and the person you're talking to, the lab and diagnostic result, and any noticeable changes, right? And then assessment. What do you suspect is the underlying problem, or what is the concern? Very clear. And then the last thing is the recommendation. This is very important because once you give someone an alternative when you're raising a concern, that person shifts his mindset from being thinking he's attacked, but rather to being he's being consulted for an opinion, right? And human nature works very well because that defensive mode immediately kicks back. If there is that nature of, okay, what do you think? This is what I think, So the recommendation and expectations, when they are very specific, they become very professional, clear, specific about what is urgent, and clear about request, and clear about time frame. This is very important. So the entire purpose here is to use this as a communication tool to structure the conversation about the medical situation requiring the immediate attention and action. And it reduces the chance of error, right? And encourages assessment and decision-making skills. So that is what I'm trying to say here. Nothing new about rehabilitation team, just to put the picture again, but not all of this we are privileged to have in our settings. But just to keep in mind, things and professionals like chaplains, religious leaders are also very important in patient care in our context, right? They do wonders sometimes. Just having a conversation with them about patient belief, things like that. If the hospital do have that, do try to engage that. They help, right? Not all these professionals are very available, but recognizing that all these professionals or some of these professionals might be available in your institution, and they think differently from the way you think, even though you have the same patient in front of you. The doctrine of training, I can't emphasize more, the doctrine of training is different. So you have to really take into account the doctrine training for each profession, how they think, how they relate to things, and how they do their own way of things. So that way you can be on the same page. And then just quickly, 11 tips for a better communication, effective team communication. So never dismiss people's concern. Acknowledge them, say yes, and then you can offer what you think. That way it works and it makes wonders. Secondly, define the roles and make the goals very clear. The boundaries I've mentioned. What is your lane? What is the shared lane? And what is the other side lane, right? Learn how people think. You learn how people like to communicate to. So people are different. Not all size fit all. Some people are very structured. They prefer direct, straight communication, very clear. They don't take it too personal. Some people take that arrogant, right? So understanding the dynamics and the people you relate with is very important, especially when you step into an institution quite new. Taking some time to understand that before engaging really helps a lot. And then raising a two-way communication, including feedback and survey. So trying to be honest, right? It's not just about winning. It's never about winning. It's about really professionalism. Try to embrace feedbacks, even if they don't feel as if that is what you want to hear. But being honest about what is the right person, what is the person saying really helps a lot. And be clear about your mission. So what exactly are you trying to communicate to that person? Take out all the noise and be very clear about what is exactly I want this person to get out of what I'm saying. That helps a lot. And have an open door policy for the seniors, right? Do not make it very hard for juniors to be able to access you and share their concern or their observations with you. That helps the rehabilitation team to move forward. And know your people. This is just exactly as learn how people like to be communicated to. So know your people. That really helps a lot. No one size fit all. Do not forget to have fun, right? Being too serious all the time doesn't really help, right? Having that human side of routine living with people and working together helps a lot. And then being intentional can help as well. So try to be mindful, make formal conversations and training available, right? And then leveraging technology. And it's not all the case that all the time meeting in person helps, right? Sometimes writing the patient case note is as good, is much better than even confronting the person to have a conversation with that person. And remember, in most cases, face-to-face remain very, very important. I know we have WhatsApp. I know we have so many ways of communicating, but face-to-face That is really so. Well, the importance of Teams Forum, nothing new again. It's just online asynchronous communication tools supporting collaboration. They have supporting collaborative decision making can be purposeful in rehabilitation. They can be able to augment sharing treatment progress, enhancing interdisciplinary understanding, and foster team cohesion. So it's just about hybrid way of working these days, right? So the main goal here is of all what I'm saying is really about better patient outcome and really promoting transparency and accountability without having saying, oh, I think he was trying to do this to me, but rather this is the accountable this decision that was made in written, for example. And then building trust and respect among teams. That is also one of the main goal of information sharing. So quickly, how do we make decision on what do we do? Do we meet in person? Or do we need to just chat over email or any other medium that the hospital is using? I try to find something that could be helpful. I think this might really work. So if you're trying to arrange a meeting, maybe a ward round, maybe a case conference, maybe just a visit in the office, the question is, what type of meeting do we really want? Is it like, what is the main thing that we're meeting for? Is it just sharing information about something, about a case? Or is it just an update about how far a patient has gone? Or is it a feedback that we want? Or is it just something that we are trying to rub our minds to be able to figure out how to move forward about the patient, right? Or is it something new that comes up in the hospital, like certain project? Or is it something that we want to generate an idea about doing things differently or solving a problem? Or is it completely not any of this? It's just about building relationship. Perhaps the OT department never have had any meeting with the physiotherapy department. And I'm pretty much sure, not necessarily if that is the case, physiotherapy will be able to know exactly what the OTs are doing or what is the nature of the way they work. So is it about building relationship? If it is really about sharing information, which is the first one, then the one thing we have to decide, is it a sensitive or complicated issue? If it is really it is not a sensitive or complicated issue, then I think sending an email saves a lot of effort, or any other digital means which the hospital has provide as a channel for communication. These days, there are electronic health record that you can type recommendations, comment about patient, and the next person that will open the patient case file could be able to see that. Or maybe even writing on the patient case notes could help there, if it is not sensitive and complicated. If it is really sensitive and complicated, right? And there's a clarity on the purpose, right? Then we need to arrange a meeting. But if it is just about brainstorming ideas and it is just or sharing information and it is really complicated, and it is not really complicated or very sensitive, then scheduling a personal time to plan the objectives will be much better. And in this case, it's always a next step before the meeting. So don't just walk into meeting without having a very clear plan of what needs to be achieved. Even a heads up that, hey, I'm coming to your office to discuss this, will really go a long way, And then that person is prepared rather than just stepping in and initiating a conversation that he or she might not be prepared, and you end up not getting what exactly you want him to do. So I think this could really shape how we think about meetings as a process rather than just nice to have or just I want to do it approach. So setting up a meeting has context. It's not just the room. There are 6 things that we need to take into account, and these contextual factors include the room, the type of facility, the time, resources, the service model. Is it an out or inpatient clinic that you're running? How many staff do you have? What are the alternatives and other available services, right? So meeting input, but what is it exactly that you want to contribute? That the personal presence is very important. You need to prepare that beforehand. The knowledge about the patient history, current capacity, performance barriers, and facilitators. Active and goal-oriented contribution. So be very, very intentional. Then the mediation process, right? The meeting structure. We need to set a specific agenda, specific documentation process, and we need to use standardized assessment tool. And then we need to do goal setting and action planning, right? And the mediation process is about Who chairs the meeting? Remember, we mentioned that a meeting without a chair is as good as nothing has been done because there is no driver, right? So having a chair is a very good skill and it's timekeeping, right? So we need to also determine the nature of the talk. Is it it's just a brainstorming idea thing, or is it a decision thing that has to be very accurate? And then we need to decide on the leadership skill because sometimes power dynamics differ. In some institution, the most senior get to speak first, and then the junior has to listen before he or she speaks. Or in some cases, some institutions, the junior is always given the floor to speak first, and then the senior follows up. Because in our society, hierarchy really matters a lot. It's not flat, right? And then power relationships is something we have to take into account. Then the team and the social climate, right? Is it a professional or is it patient focused? Professional, I mean, is this between us as a professionals, or is it really something that concerns a specific patient? Is it something that concerns the team working together? And what is the atmosphere? And what is the team interaction and interpersonal relationship? The last two is the output. We need to be very specific about what is the output of this meeting. One, is it an information exchange that we want to get out of the meeting? Two, is it a progress monitored? Is it a decision that has to be made? Is it an action plan that has to be agreed? Is it a goal that needs to be reviewed? Or is it an action that needs to be allocated? I think many meetings will never fall out of this, one of this or combination of this. So knowing exactly the output of the meeting helps to determine where is the meeting going and where is it going to end. And then the futures of any successful meeting is that it is either comprehensive or holistic. It is very objective and relevant. And in clinical case, it is patient focused and respectful, right? Patient privacy and also professional privacy, professional respect, right? So it is also timely and accurate. It's not just something that you walk in and start talking about how's your family, blah, 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 blah. And then before you know it, 30 minutes or 1 hour is gone, right? So it has to be very timely and accurate for the purpose it was designed to achieve. And then it has to be concise, not talking forever, but also consistent on the purpose. That makes it very easy for anyone to be able to want to talk to you next time, right? So the benefit of online forums is becoming a norm these days. We are doing it just now, right? To have discussions online. So the depth of the conversations allow some reflective responses, right? Having breaks, having time for people to think about what you say because of the cognitive load is something that needs to be taken into account in online forums. So we need to also make sure we foster collaboration, know who is speaking, from where are they speaking, and what is the idea of what is the idea of what they're trying to say. So also record information, right? How many people attended, who was absent, blah, 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 and all those things that are relevant. And then it's always the case that visualization of interactions and identifying active participants is very useful because as I speak now, probably someone is just hanging around, chilling with the earpiece, listening to me, and not necessarily having the intention to really contribute in terms of speaking, right? And some might be very, very prepared, sitting down, taking notes, probably having specific things that they're trying to iron out in terms of what we're discussing here that could help them or useful in their own workplace, right? So there are challenges. It's not just about the benefit, right? There are structural problems. Interface design and hierarchical navigation, limited visualization tools for tracking interaction. Things like Zoom have their own advantage, have their own disadvantage. Each tool has its own advantage and disadvantage. I will show you what that means. But in this case, many institutions adopt specific tool that they think is more useful and handy to their workforce. So I advise sticking to what is within your institution. And then engagement barriers is the motivation for people to contribute and their resistance to adopt new tools. Some people will adapt easily. Some might find it very difficult. So I will skip this, but it's applicable to all professionals. We need to be able to have communicating technical details very clear to non-specialists. Some people are not necessarily the techie type of people that are most especially the old savvy seniors, right? The new generation, Gen Zs, are very good with all these things, but some seniors are not necessarily good with all these things. So we need to take that into account. And encouraging active participation in busy schedules is very important. So strategies for effective presentation. Prepare. we mentioned this earlier. Understand your audience, prioritize relevant information, clarity and brevity, avoid jargon, and be logical, and also have something that encourage interactions and encourage questions and feedback. So yeah, specific role considerations. It applies to all domains, not necessarily physiotherapy alone, but OTs, PRO, and other professionals here. It's very important to use the ESPER tool or any tool that is similar to that in structuring your conversation and adapting it to your specific discipline. It's not a one size fit all. So etiquette in Teams forum, right? How do we really engage properly in Teams forum? We've mentioned this, but just a recap. There's certain etiquette. First, we need to be punctual. We need to be prepared. We need to speak clearly. We need to actively listen and participate. Not just listen, but listening to understand what the other person is saying. And we need to give others the opportunity to speak. And we need to follow the agenda. We need to ask clarifying questions and be attentive with our body language, right? So technologies, there are many tools, right? I'm not advocating any company here, right? I have no link with any company. It's just something that I think we could put out some lists that we can try to play around. So there are things like Microsoft Teams, Zoom, what do you call it? I can't even remember the names.
Google Meet.
Google Meet, exactly. Yeah, so there are quite a number of them. I don't know all of them by heart. There are other things that you can use to schedule meeting like Doodle. I don't know. There are a lot of them these days. If you Google, you'll find them, or even if you ask ChatGPT, right? So and then there is also tools that support multimedia integration. So presentations that would require multimedia integration, like presenting with demonstrations. There are also things like that support video and other things that one can use. And we have to really be cognizant of creating a positive environment. Some people are disabled, having difficulty hearing, having difficulty listening, seeing. So all these things have to be intentional in the way we choose.
Antibiotics.
Pardon? Sorry? Could you say that again? All right, so this is something that we need to take into account, and we need to monitor how meetings are going. We need to make recommendations for future meetings. So we need to track progress. Yeah, virtual meetings. This is true 2023 statistics, but it's still almost relevant until last year. I'm not sure of the 2026 if it is yet out. But there are certain days for which virtual meetings are very, very worst days. So try not to set virtual meetings on Mondays and Fridays. The best day for a virtual meeting is Tuesdays. We're setting one on Saturday, right? And so I don't know for Saturday and Sunday, but yeah, worst days are Mondays and Fridays, and best days is Tuesday. And it is just from one institution that 80% of the employees prefer to have meetings in the morning, not right after lunch break, which makes sense because mostly after lunch break, we're already exhausted. And 10 or fewer, they want to have fewer people on the meetings, which makes sense in clinical setting, right? You cannot pull everyone at the same time. So it's always the case that in clinical setting, we have fewer people. And then 46% of online meetings last year, as of that 2023, were between colleagues, right? So you can think of it between your teams, right? Rather than interprofessional teams. And then here's the most popular multitasking people do during meetings, right? 70%, 76% of people were doing other work-related meetings. So if this meeting was actually on Tuesday, on Monday, some of you might be already writing patient notes while listening to me speak, right? Which is really true. So one has to be very cognizant of that. Not all people will give you 100% attention when you're speaking. So you need to be very cognizant of that. Some people in this organization, 68% were checking email while attending online meeting. 50% were messaging friends, family while in the meeting on WhatsApp. While 20% were browsing through Twitter, Instagram, LinkedIn, name it, trying to just through in the meeting. And then 13% were reading news. So this is even more pronounced in Gen Z, right? I mean, it's very common that whatever they do, the phone is in their hand, flipping through it, even attending to the patient, checking notifications. So we need to be very cognizant of that when we use virtual environments for meetings, right? Yeah, so the other things are just 25% of working pro, they feel pressure when you ask people to turn cameras. So not everyone would like you to have to ask them turn on cameras. But in professional setting, I think this should be, I mean, in a team of 5, 6 in your department, turning cameras should never be an issue, right? Especially working hours. So 75% said they want to use Zoom. And then 4 in 10 employees only clean the room that is visible to the camera. So don't expect people room to be 100% clean. Some people just make the area where they will have the meeting to be clean, and then the other side is completely a mess. It's just some things to keep in mind. And then over half of the people having virtual meeting turn off the camera and they were just eating their noodles, or whatever it is. And then 42% use their phone to even make phone calls. They're in the bed just listening to you and then doing other things. Some even having shower, right? And then 75% of Zoom users wave goodbye at the end of the meeting. I don't know how many will wave goodbye at the end of this meeting, right? But that's what happened. So most popular days for Zoom calls, Tuesdays, Wednesdays, and Thursdays. Benefit of virtual meetings, it is easier. Of course, we are very different time zone, very distant, but still having a chat together. It is less stressful. You're at home stretching your leg in your pajamas. It is also just as productive as in-person meeting if it is done properly, and it is easier to contribute because the pressure is less, and then it makes participation even more equal, right? So of younger employees, they experience anxiety for excessive Zoom meeting, and that is very common because Gen Z, again, they prefer something very fast because they're used to swiping Instagram, Twitter. So we need to be very accountable. The attention span has shifted a lot with the generation. So little digital literacy, and that's the end of the lecture today. We need to take into account that using these tools is not just using them, but we need to prepare ourselves to use them properly. Most especially we that are healthcare professionals, all of us here, we are dealing with patient privacy, which in some cases could lead to legal issues if not done properly, right? So we need to be very, very careful on how we use these digital tools. One, because you're not alone if you use them. You don't own you don't own Zoom, you don't own Microsoft. Whatever you use them for, someone out there is at the end having all what you've been saying stored. So he can listen, he can watch, he can do whatever he wants to do with the data. So, and sharing patient information is something very, very, very critical, right? So we need to be very aware of that. So critical thinking is very important. Internet safety and cybersecurity knowledge is very important. We don't need to be expert, but we need to be aware of them. Digital search skill is very important to find the right tool, read through the privacy terms, read through what is being done. And then online identity management is very important because these days, your facial identity is a gold mine. There are companies out there that just really want to have your face, really want to have your voice. They even pay you to just share your voice with them because they use it for artificial intelligence and other things. So I don't want to go into definition of digital literacy. I've already said what it is, but trying to understand what is needed to be able to be very efficient in this digital era is try to have practical and functional skills. How do I operate the tools? How do I craft and use them in the way that benefit me? Secondly, we need to have critical thinking and evaluation. Is this really actually for us? What exactly do we need? E-safety, like I mentioned, data breaching, cybersecurity, cultural and social understanding. Not all culture want you to put camera on them. Some people, for really religious reason, for cultural reasons, do not really want camera on them, for example, or any other issue. Or some would really like to have that. It depends. So we need to be very cognizant of that, especially now that the world is becoming more global. You have meetings online from people from other part of the world. So collaboration is very important. Curate information is very important. What do you share? Proficient communicator is very important, and being creative. So Yeah, these are some of the things. There are challenges. I've already mentioned it. Lack of clear communication, poor attention span, lack of formal relationships. Very hard if you're meeting someone for the first time. Scheduling time zone difficulties and technical issues. Sometimes they don't really work. Yeah, there are things that you can have meetings with them and then be able to even feel like you're live, chatting, drawing things and things like that. Again, I'm not advocating for any company here. I don't know them. I'm just saying it for the sake of knowing them that they're available. We can use them. But just a simple chat as of 2022, people use Zoom the best, and Microsoft was second. There's something called GoToWebex. This might have completely changed again because this technology move very fast than anything these days. So the statistics might have completely changed. But just to tell you that there are certain things that people would really want to work with and people are working with. What we have here is just to say, when do I use what?
So that I will not stress myself and
So
our children.
for
So very, very easy. From Amman to school days, can we just go and understand? Very, very easy.
so I think the person can mute himself. So
We don't understand about it.
for depending on number of people that
Inside school,
could you mute yourself, please?
inside school, area, inside school,
I think is favor, right?
We're going to ban.
Can you mute yourself, please?
So that I say, okay, can we meet with brother John Paul? Stand up in Jesus' name, boss. Okay, so you put your phone.
Okay, so let me quickly wrap up. I think he's not listening. So depending on the number of people that will be in the meeting, we decide what tool to use. So for one-on-one meeting, not necessarily bigger tools. For small group, not necessarily bigger tools. For people that are up to 50, then tools like Zoom are very useful, right? And for people that are more than 100, like 200 plus, then Zoom, things like Google Meet or Microsoft Teams or Skype might work. Inclusivity, I've talked about it. Importance of having these digital skills, I've spoke about it. Five taboos that you should never do in virtual meetings is don't arrive late. I've said this. Don't use your cell phones. Don't interrupt people when they speak. Having no agenda, just showing up without having nothing to contribute, or eating during the meeting. Yeah, this is a very soft ending, I guess. And I will stop here and take any questions or comment or contribution that might help all of us here for this lecture or the two other lectures that we've had before this one. Yeah.
Thank you so much, sir. It was really elaborate. I don't know if anybody still have any question or comment. Hello, can anyone hear me, please?
Yes, we can.
Okay. I was asking if there is any. Okay, someone's hand is up. Ajib Sani, please can speak now.
Good afternoon, sir. Good afternoon, everyone, for being part of this session. I'm very grateful for all the knowledge and skills we have learned on this platform. Concerning communication, like when we say interdisciplinary and multidisciplinary communication, we know as Nigerians, we have some issues going on. There is what they call this cooperation among different health practitioners. It's still not something we have achieved fully, because in some universities, some physicians know about rehabilitation. Other universities, they don't offer rehabilitation courses. So there's kind of misinformation or no information about what rehabilitation entails. Even some nurses, like in School of Nursing or College of Nursing, they don't have any information about rehabilitation. So this can kind of bring issues when it comes to interdisciplinary or multidisciplinary approach. Understanding, except for maybe physicians that are into that are specialized in areas that are related to movement, like let's say in neuro, in musculoskeletal, integumentary, cardio, these areas. So these individuals tend to a little understand our views, our concept, our intentions. If not, some don't even know physiotherapy is supposed to be referred to or to be called to be part of a particular case in during ward round. So we are not always involved. That's why we start engaging with patient on a later or subchronic stage of pathology or impairment. So my advice is that we should just keep trying to communicate to them. Like recently, I had a patient that undergoes cervical surgeon, and he has an issue with it's a decompressive surgery, though, because of there is weakness on a particular area of the body. In fact, both upper limbs and lower limbs because of neck trauma. So communication, though they talked to me through phone, but there was no referral, and there was no information about the patient on the EMR. That is we use DHS where I work.
Okay.
That's Digital Health Services.
Okay.
So we couldn't access his information. So if not for the first contact practice we are learning, we wouldn't have. We were just like, okay, let's wait for their own information. But as we go on, I think we should all be engaged in first practice. Any courses that talk about first practice, first contact practitioner, like this course we just take now, is a first contact practice. It's not a soft skill, it's a clinical skill. This can help us to have information that we will not get from all these from the other healthcare practitioners. So we can be communicating to them to tell them this is what we are doing and this is what we want from you. What kind of surgery do you do? Things like that. But it doesn't mean that if we don't get any information at all about the patient, meaning we cannot go on. Because in acute care, acute care practitioners, they really need the information per se. But those that are not in acute care, like the outpatient, they can still go on. Only that if there's no red flags, yellow flags, and there is need for referral, they will refer. So this is just what I want to say. Thank you, sir, Dr. Usman Sani Dankoli. We really enjoyed this session.
Thank you so much, Najib. That was really a very good recap of entirely what we have spoken about in the first lecture and also in the subsequent ones. Yeah, indeed. Like I said, if you remember, I mentioned about now rehabilitation being centered as a primary care by WHO after 75 years, right? It's just happening in 2023. So I think with this is a very huge leap that now healthcare professionals will begin to be aware of rehabilitation as a broader entity within the healthcare intervention given to patient. So I think moving forward, things will definitely change. And having the first contact model really helps. If you remember, I gave the example of how we've used the first contact approach in musculoskeletal issues in the state where I worked earlier. And it helped a lot in really boosting the physiotherapy department across the entire state, revenue that they generate to the hospital. And that gives them a lot of leverage in terms of what they ask the management, what the management listen when they speak about. So I think that's a good thing. And I think another very important thing is that the thing you mentioned about speaking with them. So hospital presentations, they exist somewhere in some hospitals, but not all hospitals have that institutionalized time in a particular period in time where certain departments come together, or at least representative from all departments come together to solely talk about clinical cases, nothing admin, purely the workflow that happened with patient. So I think sharing up, if this doesn't happen in your facility, taking the step forward to bring this as an initiative would be a very good step, because then it's not just about you. You make the hospital realize that, oh, we've been working without talking to each other, right? Talking is happening, but only about money and admin in the top, but not necessarily about the patient in a broader sense. So they might happen in small ways. When you see a colleague in bedside, maybe a resident seeing the patient you happen to know in the ward, or maybe the surgeon having to refer the patient and seeing your name so many times on the patient case note. So things like this do happen, but not in a formal, organized way. So if we can take initiative, it works. I tell you, it works. Taking the initiative to bring that into the institution as a change, big or small, that helps a lot. But thank you, Najib, for that contribution. Yeah. Yeah. Are there any more contributions, questions, things you want us to benefit from? Don't be the data holder. Share things that are useful. Yeah. Right. Yeah, the host can take over, and if there are no questions, then yeah, thank you all. Thank you all for the message in the chat. Yeah, it's great having to share this hours with you. I've learned a lot, and it's so interesting to have such a platform to share knowledge and learn from each other. Yeah, these are things that we not get it from books. So speaking to each other is something very useful, right? Yeah, thank you all. Thank you. Thank you. Thank you. Thank you. Thank you, Samuel. Thank you, Farouk. Thank you all. I will leave the slides with MRTV, and yeah, they'll take over from there. And then the names I've took, I would also share the mobile data gift, MRTV, and they will reach out to you. Najib, Oluwasiu Mary, Georgiana, and Esther. All right. Bye.
All right, I got my guys. Hello, please can anyone hear me?
Yeah, I can hear you.
Hello, please can anyone hear me?
Yeah, I can hear you.
Okay, I got logged out briefly and I'm back now. I've been struggling with the network. Thank you once again, sir. The lecture was really elaborate. You poured all into it. And regarding our certificate, it should be ready within the next 72 hours. That is on or before Tuesday. You will have your certificate and the learning materials in your email to be sent via your email. And with that, we've come to the end of today's workshop. Goodbye, everyone, and have a lovely weekend.
Goodbye, all. Hope to see you next.